to us about today. We've been advertising, the Schwachman-Diamond Syndrome Foundation has been advertising this study for about a month, I believe, and we wanted to answer your questions that you have. Again, the SDSF Live is a public broadcast. We do not want you to write any private questions on here. It will be uploaded to YouTube, so please do not write anything private on this.
Yes, thank you for joining us. We're excited to be back with you guys. It's been quite a few crazy weeks, but we missed everybody, and we know this is a very important subject, so we wanted to get it out there as soon as possible.
Hopefully everybody is home, so maybe this is a good time to talk about this. I know everyone's very busy with the coronavirus, but this is also very important to our community. And if you're home and able to pay attention, not busy with normal life, maybe this is a good time to chat about this. We're going to wait for people to log on. While you're logging on, please let us know where you're logging on from.
And then while the conversation is going, we asked a few different times this week if you had any questions or reservations about the study. We encourage you to ask those as the broadcast is going, even before it starts right now. We want to, this is for you. We do this for you and for everybody else. So we want to answer you the best that we can.
Some of you might have met Dr. Tobin at camp. He's been at 2 Camp Sunshine so far, and we thank Dr. Tobin for using his personal time to come to camp.
My pleasure. It really is. You guys are great.
Thank you. So we're just going to give it a couple of more minutes to let people join. Oh, we have someone from Orlando, Florida.
I love Orlando, Florida. When we went there, it's not even for like the attractions or anything, but the weather was just beautiful.
I'm wondering how everyone in Orlando is handling the Disney shutdown.
I wonder, because that's got to be a lot of employment. If you think about it, it's not just, traveling, it's
Exactly.
it's employment.
We've had a lot of diabetes conferences in Florida as well because the hotels are so accessible.
I hope you have someone from Denver.
Interesting. I wouldn't have ever thought of that to be a reason. It's interesting.
Just a reminder, we're going to have Dr. Lou, an adult SDS hematologist, on Sunday. So please, we've been advertising for that as well. We kind of put that together really quick, talking about SDS and coronavirus. So we're going to be doing 2 SDSF lives within 2 days.
So please bear with Nicole and I as we may look like zombies. Again, we are just 2 moms who live in 2 very different time zones. And we do the very best we can because we love our community.
So this SDSF Live is brought to you by the Schwachman-Diamond Syndrome Foundation. The Schwachman-Diamond Syndrome Foundation provides support to families around the world, SDS patients around the world. I'm very proud. Michelle and I are both board members of SDSF, and we're both very proud of how much the board members are supporting our community right now and everything we're doing. And this study is very important, and we're happy to talk to Dr. Tobin today. So we're going to give it 1 more minute, and then we'll start our questions. Hi, Dr. Tobin. How are you today?
I'm doing well. You guys look great.
Thank you. You do too.
Thanks.
Can you tell us a little bit about your study, Dr. Tobin?
Yeah, I want to basically say thank you for the foundation for the support for the study. This study has come out of significant discussions that we've had throughout the camps, as well as discussions across the diabetes community and the Schwachman-Diamond community. One of the main aspects of Shwachman-Diamond syndrome, besides the hematologic aspect, is the loss of the pancreatic function, which is really early on in the disease. And there's a lot of similarities between Shwachman-Diamond pancreatic insufficiency and what we see in cystic fibrosis, where we see a lot of diabetes at the level of about 50% of kids or adults, depending how you look at them, by the third decade are diabetic. And we're actually seeing diabetes in that population show up even as early as age 5 or 6, depending on how we're screening them. And they've proven in the cystic fibrosis population that controlling diabetes, trying to prevent diabetes, will decrease the risk of infections and actually improves outcomes after transplant. And the question that I'm proposing in this study is to really find out who has diabetes, what age does it develop, how does it develop. We know that the pretty good significant proportion of patients with SDS as they become adults will develop glucose intolerance. But unfortunately, your guidelines from the SDS Foundation or societies does not even include glucose screening as part of the aspect. So what I'm hoping to do, and I'm hoping that the group out there will do it, is to have the families and the individuals affected with SDS to help me learn what the prevalence of diabetes is.
So interesting. What made you want to do this study, Dr. Tobin?
Well, I first met my first individual with SDS was Michelle, Joan's daughter, who I think many of you know. And she used to call me Pain, and I really enjoyed taking care of her. And Joan, as you're all well aware, is a hard person to say no to. So she managed to get my group to come to camp. And by doing that, I had to learn more about your disease process. And it was a natural question of why did they develop diabetes? Why did they have glucose intolerance? What's causing it? And then meeting the scientists at the camps and looking at their studies, they've actually shown in the animal models that diabetes is a signal that you can see. So I think it's going to be important to diagnose and possibly prevent if we can learn how to prevent it, which I think may be the case in this situation.
Dr. Tobin, what does the SDS registry data suggest is the prevalence of diabetes in SDS patients?
Okay, so the SDS registry, as you're all aware, is primarily a registry for the bone marrow samples and things that they're going to use for clinical studies. But they also collect data that you will sometimes send in that includes, hey, I've got diabetes, or I have glucose intolerance, or I have growth deficiency. And they looked at the data there, and out of the population, only about 25 people were registered in the study. There was approximately 20 to 25% of those patients reported glucose abnormalities. So if you take the group as a whole, let's say not everyone's participating in the registry, and we look at it and say 25% have diabetes, we're looking at probably a similar incidence of what you would see in the CF population.
That's really staggering. That
Interesting.
really got me. That was new news to me.
I mean, I presented that data.
Cystic fibrosis was.
Hang on a second. I presented that data
Go ahead.
to the families at the SDS meetings in Maine, but whether or not it registered or not, when you're overwhelmed with everyone talking to you, I don't know.
Yeah, the meetings, the camp.
So what are the... Go ahead, Nicole.
I was just going to say there's a lot of information at camp, and it's hard to digest all the information coming at us. So, yeah.
But I think that the concept of how do you screen for diabetes is really simple. If we give someone a sugary drink or what we call a glucose tolerance test and measure their blood sugars before 1 hour and 2 hours afterwards, I can give you an answer of whether or not you have normal glucose tolerance, impaired glucose abnormalities, or frank diabetes. And depending on what we find will determine what the course of treatment should be. Most patients with pancreatic diabetes or diabetes related to pancreatic insufficiency utilize insulin therapy, but we're not sure if that's always the case or always needed. And this will also help us understand that as well, because the group of patients out there with SDS who are already diabetic, I'm asking them to participate in the study as well so we know when they were diagnosed, because that's an important data piece that we need to correlate for everyone here. And then one of the other things I'm interested in is...
So what are the cystic fibrosis?
I'm sorry? One.
Sorry, there's a little bit of a lag between us. I'm sorry. Keep going. You're fine.
I can't remember where I was at. So please ask your question.
Okay. What are the cystic fibrosis guidelines for testing?
So the cystic fibrosis guidelines suggest testing with oral glucose tolerance tests by the age of 10. Unfortunately, the data that's coming out now shows that glucose abnormalities are seen as early as age 3 or 4. And so testing at age 10 is probably going to be moved back sooner, with the idea that early treatment may decrease, some of the problems there. That's an evolving...
That's really interesting to hear that it comes soon. And can be tested that soon. I remember it's always been, a mid-adolescence type testing.
Yeah.
But I think the key is that the pediatric doctors don't see the adults as much as I do. And the nice thing about the cystic fibrosis group is that most of them are making it to the third, fourth, and fifth decades now with the new drugs out there. So we're really learning a lot more about that as well. But having said that, I think it's just an important piece of the puzzle that needs to be documented and then addressed in terms of treatment. It's certainly not going to be the primary problem for anybody with SDS.
Right. We're going to take a quick break for questions. Again, if you have any questions about SDS and diabetes, or you've seen the study and have any reservations or would like to ask Dr. Tobin any questions, now is the time. I just wanted to tell you, Dr. Tobin, we have people logging in from Orlando, Florida, Denver, Ontario, Arizona, Denmark.
Watching from Cincinnati.
Yes. And I'm from Houston, and Michelle is from Michigan. So, and Dr. Tobin, you're in St. Louis. So we love Facebook Live because we could all connect to talk about this. So our first question for you from one of our guests is, I have diabetes. Is there any data showing that my son is at higher risk than a child of a non-diabetic?
Okay. I'm going to paraphrase the question to make sure I understand it. The person who has diabetes, do they have SDS?
I believe not.
Okay. So a family history, mother or father with diabetes, will increase the risk for the child to have diabetes as well. I'm not going to quantify that to a great degree, but type 2 diabetes, which has a significant inheritance, it can be seen in the offspring of those parents or children, depending on how it develops, if there's obesity or other things going on that may increase the damage or stress to the pancreas. That's one of the questions I'm trying to answer in this as well, because I'm asking parents to fill out a study to tell me if they're diabetic, which will help me look at, do their children with SDS or their children without SDS develop diabetes as well? We don't know the answer to that question, but the standard answer to the first question is, if you have diabetes, your kids are at higher risk.
Right. So they may have a genetic history and this predisposition from SDS, so that may just speed it up. So that's one of the things you're trying to answer. It's an interesting question. We have a new guest from New Jersey. Our next question is there an age range an SDS patient may get diabetes?
Okay, can you repeat the question?
Sure. Is there an age range an SDS patient may get diabetes?
I can't answer that question completely, but I'll go back to the animal models, which about a 1-year-old animal model starts showing signs of glucose abnormalities that can be seen. Rats aren't humans, mice aren't humans. My prediction is if what holds true in the CF group is similar, I would say it's going to occur, the clinical diagnosis of diabetes could occur in the second and third decades. I think the preclinical diagnosis of diabetes is probably present early on, maybe as early as age 5. I don't know.
So interesting. Michelle, are you still there?
I'm here. I have a really big lag, and so I don't know when people stop talking.
Okay.
Yeah, so I'll jump back in just a second when I can figure out my lag out.
Well, no problem. Okay, I'll just continue. Sorry, Dr. Tobin, this live is really exciting, but we sometimes have live comes with sometimes technical issues. Michelle, just let me know when you could join in. Does diabetes in SDS patients differ than the general population in the way it presents?
I would say that that's absolutely true. The reason I'm going to say that is that we actually classify diabetes in 3 different categories usually. We call type 1 diabetes, which is an immune-mediated diabetes. That's actually been seen in some SDS patients. There is type 2 diabetes, which is what most of you out there are familiar with. Usually occurs later in life. And then there's what we call secondary diabetes, or diabetes related to specific causes. And in this case, I would say that the diabetes would fit in the category of type 3C diabetes, which is related to the pancreatic insufficiency and the stress. The pancreas is an organ for digestion, but also from embryologic state is an organ for hormone secretion, primarily insulin and glucagon. And that's the part that is not directly affected by SDS that we know of, but appears to be affected secondarily, probably by the pancreatic insufficiency and the need for pancreatic enzymes. So I would predict that the individuals with more severe pancreatic insufficiency are more likely to develop the diabetes at an earlier stage. That's my prediction. I have no data.
That's really scary. I know a lot of SDS patients that need more and more enzymes, more than what the GIs recommend. That's kind of common, so that's interesting. Are SDS patients generally monitored for diabetes regularly?
Well, as we discussed, unfortunately, there's no recommendation in the guidelines. So unless they get a glucose measurement as part of the routine screening labs, which not always occurs, they're not really testing them with any kind of stress on the glucose system, which would be recommending testing after a glucose drink, such as a glucose tolerance test. The other screening method for diabetes would not work in the SDS population because of the anemia. The hemoglobin A1C is not an accurate test. So we need to measure glucose.
That was what was another new thing for me is I thought my son had been, for those of you guys that don't know me, I have a 5-year-old son. I thought my son was being monitored for this because I think I've seen something on his blood work that alludes me to believe that, but he's never drank a drink or anything like that. So you're right, he's not being truly monitored. There's no stress on his glucose. So that's the true way to monitor, correct?
Mm-hmm. And then just to jump in, one of the reasons I'm recommending we use the sensor technology as a part of this screening study is that this will give an answer to what goes on during your routine daily activities and the routine diet that all our kids are eating. We know they're eating not such healthy food, although I'm sure Michelle's kids are eating the most healthy food in the world. But having said that, this is going to tell you what you don't know.
Yeah.
And if I see that there's an abnormality and I know what they've been eating, you can make a recommendation to not eat that because you can show them the pictures.
Right.
And I think that's going to be probably the biggest eye opener on this as well.
It's like uncharted territory. This is so interesting. Michelle, how are you doing? Are you ready to join us, or?
I'm here. I was actually, there's some questions in the comments. As long as everyone else can hear me, I'm doing great. I don't really know what is going on. One of the questions that came through was, what is the normal glucose range for an SDS patient? Is it the same as a non-SDS patient?
The answer is it would be the same consideration as any other patient out there. The criteria, what is normal glucose versus impaired glucose versus diabetes, is arbitrarily set based on the American Diabetes Association. And those definitions are, you can make a diagnosis of diabetes by having 2 fasting blood sugars greater than 126, or in terms of after a glucose drink, a glucose that's above 200 would be diabetes. If you're between 140 and 200, you're impaired. It's arbitrary. There's not a significant distinction between all these levels, but the higher the glucose is, the more likely the problems are.
Another question we had come in that said, my SDS son had some electrolyte scares after his recent bone marrow transplant. Is he at a higher risk for developing diabetes? He now has to have Pedialyte to help him keep his potassium and sodium in balance.
Such a great question.
I don't think that's going to affect the glucose necessarily, but it would suggest to me that he has probably a more significant digestive and pancreatic issue. So if I would predict, I might think that he might, or he or she might be at higher risk, but I would be just guessing.
That's a great answer.
Yeah, we're gonna move to what is involved to enroll in your study. Joan is asking if you have a Libra monitor to show us, so we're hoping that you'll show us during your explanation of what's involved in enrolling in your study.
So, are you asking me to explain who's involved or who should be involved?
Well, what is involved to enroll in your study?
Okay, so in order to enroll in the study, what I'm asking the families as well as the individuals at SDS to do is to sign the consent form for us. And what we are recommending that we're going to do is take a health history from the family as well as for the SDS individual. And then we're going to do a oral glucose tolerance test where we're going to have the individual drink a sugary drink and then measure blood glucoses at baseline 1 and 2 hours afterwards. We're also planning on obtaining other laboratory tests for other hormonal abnormalities that we think might be affected by SDS. Some of these we may not need to draw if we can find the laboratory tests have been done previously. And then once we've done those baseline laboratory tests, I'm going to have each individual with SDS wear a continuous glucose monitor, which is something that you put on the arm. And you're going to see me put up in front of you a disc the size of a quarter that we would place on the arm. And this is going to measure glucose for the next 14 days. And that information would then be given back to each of the individuals in terms of how their blood glucoses are affected by their daily food intake. So the baseline here is contact us, sign up do the health history. We'll organize the blood draw where you would normally go to get your blood work done. And then we would send to you the Libra Freestyle test kit, which would be placed and left in place for 14 days. And then that would be mailed back to me, and I would download that information. And then I would send you back a report on all the laboratory tests, as well as the glucose. And then hopefully at camp, I'll be able to tell you how many patients I've found with abnormalities if camp occurs.
What are the benefits of this study?
I think the benefit of the study for each individual, as opposed to other studies out there, is that I'm going to give you direct feedback on what the current status is of your child with SDS in regard to hormonal abnormalities and glucose. If I find something, you'll be able to discuss treatment with your appropriate physicians. And we'll also be looking then at what caused it by looking at some of the other tests we're drawing with the blood work here. So I think the benefits are twofold. One is I'm going to give you a direct answer of where you stand now. And we're going to find out a prevalence, which is how many people have this problem. And then hopefully we're going to set up a screening program that's going to occur on a yearly basis to determine the rate of conversion. And then if we can intervene to stop conversion by some potential therapy, I'm hoping to see that become a improved problem.
So besides what you've said, what are the benefits of doing this study? What is the end goal?
The end goal of this study, first and foremost, is to create a baseline database that gives us a picture in time of how many individuals with SDS are suffering from glucose and other hormonal abnormalities. And then it'll give us the ability to then determine, by looking forward down the road, how fast or how often people convert from being normal glucoses to abnormal glucoses. And as people are well aware, type 2 diabetes increases as people age. So we would see problems develop over time as people get older or have other health problems develop.
The next question we had was that my genetically confirmed son will be 3 in the beginning of July. Is there a deadline to join? And can he join once he is 3, or should I sign him up now?
Okay. I would tell that individual that they should wait until their son is 3 to sign up, but we would be glad to talk with you ahead of time and start working on getting the health history forms filled out and arrange for the blood work to be done and the testing to be done. So yes, I would be glad to talk to that individual or have you focus in on us. I wanted to say the reason that we're focusing in on genetically defined individuals as opposed to clinical diagnosis is that I'm looking to be able to answer the question in a more homogeneous population. And we already know that not everyone has the same SDS, even though they have the same genetics. So the clinical diagnosis will be something we would look at later once we have some information in the majority population.
Is there a deadline, Dr. Tobin, to join?
I'm sorry, what's that?
Is there a deadline to join?
I'm sorry, there is no deadline to join other than the fact that I'm trying to do this study, get this baseline study and the follow-up data done over the next 2 years. I'm hoping that by getting the baseline data and a follow-up in 1 year, that we can get a significant information out there to determine whether or not this is a big enough problem to address more resources at. So from my standpoint, the earlier the better. I'll take you whenever. And we'll work with you is what I'm trying to say.
So can we just outline who should apply for the study? What are the baseline requirements to be able to apply?
Okay, the baseline requirements is to be genetically diagnosed, 3 years of age or older. I would recommend, I'm not asking, and I would probably ask that the people who have been transplanted not sign up, although I would love to have them sign up, and we may not do all the testing just to get the history. But other than that, the only distinction is if someone has been in the hospital, we're going to delay any blood draws until they've been out of the hospital for a couple months. We want to test people when they're relatively healthy, not when they're stressed in the middle of an infection. So the only clear distinction here is age and clinically diagnosed.
You mean genetically diagnosed, correct?
I'm
It's
sorry.
okay.
Genetically
okay.
diagnosed. I apologize.
No, it's okay. It's interesting because I have a clinically diagnosed son and Nicole has a genetically diagnosed son. So we actually do that to each other all the time.
And that's one of the beauties of the show, is that we come from different perspectives. We have another question from a guest. What is the normal glucose range for an SDS patient? Is it the same as a non-SDS patient?
I believe we answered that question. It is the same. The distinction for diabetes is determined based on arbitrary cutoffs from normal, in intermediate, and diabetes. The distinction of diabetes for kids and adults are the same.
What are the risks, Dr. Tobin? Are there any risks? What are the risks?
Okay, so the main risk of the study would be, I'm going to be drawing blood. So, I have to go through the trauma of drawing blood. I'm asking you to put on the sensor, which is placed on the arm. And I don't expect any problems, but obviously anytime I stick a needle in anybody or have anything sitting there, there is a potential risk of infection, although we've not seen it. And we use these devices in immunosuppressed kids. That's the main risk. Obviously, you're going to give me some data related to your health history and your child's health history. We're going to protect that data just like we protect all data in the medical field. This is all going into a de-identified registry, and we're going to be sharing this information with all the other people who are interested in SDS. So I'm expecting to, as far as other clinical studies, this is going to give an answer pretty darn quick.
Who applies that monitor? Is it the doctor that applies that monitor?
So, what we've been able to show is that because this device is so simple to put in, a doctor could put it in, a nurse could put it in, but we could talk a family member into how to put it in. It is so easy. It is a spring-loaded thing. You clean the arm, and then you put this device in on the arm, and then it's left there. And you put tape over it if you need to keep it on. And it records all the data. You're not going to see anything until I download it. So we think that we can get this done by sending you a video and showing you how to do it. Or if you're uncomfortable with that, we'll find someone locally who's doing it or knows how to do it and put it in for you.
Is it similar to a diabetic needle, like a Neupogen shot? Would the child feel like, or the patient feel like a Neupogen shot when they apply it?
I don't know what a Neupogen shot feels like, but I know that it doesn't make people feel good. This is pretty painless. I'm not going to say it's completely painless. It's a small needle, and there's a little metal catheter that's left that is measuring the glucose for the 14 days.
My guess is it's similar to Neupogen, because most of us use a diabetic needle for the Neupogen. So minus the medicine, it's probably similar needle feeling to the patients. What accommodations can be made, Dr. Tobin?
Well, I want as many people to participate as possible. When I say this, if a child doesn't want to do the standard glucose tolerance test, I would do baseline laboratory tests on him, and I would try to put the glucose monitor on. I would get data from that individual. I wouldn't get some of the more specific data, but I'm asking a lot. I'm asking you guys to have blood drawn 3 times at the baseline, and then wear a device for 14 days. And I'm also asking you to fill out a health history. We're trying to get as much participation as possible, and if you have a problem with certain aspects of the study, we can either work around it or defer it. I'd like everyone to do everything I'm asking, but I know not everyone will be willing to. It's not an exclusion. We want participation.
One of the questions we had, and I know this applies to my family if we were genetically diagnosed, but is a feeding tube an issue? My son has a very severe oral aversion and gastroparesis, so drinking that drink would be very, very hard for us. So could it be done with a feeding tube?
It can be done with the feeding tube. It's not completely standardized, but it would give us the information we're looking for in terms of how your child would respond to a glucose load. Um, it should be not any different. We would document in our reporting of the data whether or not it was that someone drank it or went through a G tube. But in the end result, I'm going to combine all that data together. So a feeding tube would actually make it easier because I know that the child would get what I'm asking him to get over the period of time. I don't think anyone's going to have a problem drinking the drink. I know that all the women out there were screened during pregnancy with a glucose tolerance test, so they know what the drink tastes like, or what it looks like, at least.
One of the questions that came in was, will the study ever open up to clinically diagnosed patients? How long after do you think the genetic study is done that it would open to clinical patients?
I don't know the answer because I don't know what I'm going to find with the genetically diagnosed yet. I'm hoping that I'm going to change the guidelines completely with just the initial data, and I think I can, based on what I think the answer is going to be. So once we change the guidelines, I think everyone else will be screened with these techniques for routine care. From the standpoint of whether or not the study is ongoing, that's going to depend on funding and other things. I can tell you that the use of the sensor technology as a means of screening is emerging as the standard of care. So we may, once we have the initial data, we may be moving in that direction, and therefore it would be covered under your standard of care and may not need to be done in a clinical study.
Interesting.
Although in my mind here, if you get this data, I want the data reported back to us so we can put it in our database and use that information to track people over time. Especially if we get wonderful drugs out there that will be able to interfere with the process over time. We want to know if that changes the development of glucose abnormalities or other hormonal abnormalities as well.
Another question we had was, is it similar to an infusion needle? How large is the needle that's being spring-loaded in?
I don't have the answer specifically, but it's about 8 millimeters at the longest, probably less than that. That is spring-loaded in. It's going to be in the subcutaneous tissue. It's not really going any deeper than that.
It's good to know. Do you have any recommendations for clinical families in the meantime that I know there's not really a set standard of care, but any precautions we should be asking for or taking until the study is open to clinical families?
I think that I can answer that question better once I have the initial data. But I think anytime you get blood drawn, ask them to draw glucose. Maybe ask them, is it okay if I come and get this blood drawn after I've eaten a meal to see if my glucoses go up? There are, there's kind of simple, sneaky ways to get the answers done as well. And if you see an abnormality, then it could be, referral to an endocrine doctor or do a more significant screen, which would be the glucose tolerance test I'm talking about doing, which is the standard of care.
That's good to know.
Is this study only open to U.S. patients or is it open internationally?
If we can send the blood samples back and forth internationally, the answer is we probably could do it. There's nothing in our IRB that says we can't do it. I'd be glad to talk to those individuals and see if we can work it out. I don't have as many contacts in other countries, but I'm sure I could find someone to help us do the study, draw the blood that we're looking for. So the answer is please contact us.
So one of the last questions I think we have is, should SDS patients be seeing an endocrinologist at baseline, whether they're clinical or genetic?
That's a harder question to answer. There are some SDS patients who have growth hormone problems and are being treated with growth hormone, some who have thyroid problems, um, and some just with nutritional problems. So I don't think everyone needs to see an endocrinologist yet. Um, I think that we can hopefully educate the other doctors that you're seeing to help make that decision for appropriate referral. But if there is an issue with delayed puberty or other issues that might occur, um, then an appropriate endocrinologist should be seen.
I
Um,
believe that is in the SDS consensus. For those that are not familiar with the SDS consensus, it's the kind of document that the best SDS doctors in the world have come together and agreed upon the guidelines of what doctors, what they should be looking at, and what times they should be looking at them. So we'll put that in the link below, as well as how to join this study. There is a lot of questions about when to see an endocrinologist. Do we have any more questions? What made you want to join this, start this study, Dr. Tobin?
well, I think I was kind of coerced into becoming a SDS expert by Joan. And so I'm going to call Joan out and saying that you guys are lucky to have her, and we're lucky to have all of you. But I just think it's an unanswered question, and I've been very interested in what I call pancreatic diabetes as part of my entire career. So one of the areas that I specialize in is patients who develop diabetes related to pancreatic insufficiency and other things. Um, it's an interesting group of people, and we actually have at the university here Dr. Fumi Urano, who's working with the population that is called Wolfram syndrome. And this is another genetically determined cause of diabetes. And he's one of the investigators in this study. And he's going to be asking some of the same questions about why does diabetes occur in this population. And there's a big push out there in regard to what causes diabetes. We're learning so many different things are now causing it that we didn't know before. And that's related to all the genetics that we are now learning about. So we're looking at atypical causes of diabetes, and I hate to say it, but the SDS population is atypical, and we need to know why, because it'll help inform what we do for other patients with similar presentations or even normal presentations for diabetes.
Dr. Tobin, sometimes SDS patients have a problem drinking a large volume of a drink, such as the entire glucose drink. Is there any other accommodation that could be made for that?
The answer is there could be, depending on what we're doing. I would tell you that the amount that you remember drinking when you were in the pregnancy screen, the kids are going to be drinking a appropriate amount that would be based on their weight and size. We would be looking at ways of concentrating it if we can. I don't know. I have to look at it, but the answer is we could work with it.
I have to ask this question, Dr. Tobin, because we're in an odd time right now. We're in the middle of a pandemic. People are nervous to even leave their homes right now. Talk to us about why they should start this study now.
So I think there's two reasons here. Is that everyone with SDS still has to go see their doctors, and they still have to get blood draws. So that's the standard. Everything I'm talking about doing here is going to be done in the places that you would normally go to get your health care. Now, I would say, should someone go to see a doctor in the next few weeks, I would probably avoid seeing the doctor the next few weeks if you can. But if you have to go see the doctor and you're already going to get blood drawn, it would be wise for us to at least try to coordinate what we're trying to do here. And then the rest of the study that we're talking about doing is all done in your home. You're going to go about your normal routine and normal activity. There's no new travel here. As a university professor, I'm not allowed to travel from the university until we're giving clearance here. And they're telling me I shouldn't travel for even pleasure or other reasons. So we're all hunkered down here in St. Louis, just like you're hunkered down where you are. And if you need to go travel to your physician, we'd be glad to coordinate what we need to do when you're there.
So there's no need for these patients that join your study to travel. They could do everything from home.
We're hoping that unless they travel to their hematology doctor or other doctors, and that would be a normal travel, that would be a decision between you and the hematologist. We want to keep people safe. We don't want them to be out and about and running around. I'm fully in agreement with the health department's recommendation to stay away from large gatherings. And I'm fully in agreement if you're sick to stay away from people. And you got to protect your kids and you keep them away from them.
Yeah.
Yeah, I don't know if you saw today, Dr. Tobin, Joan put out a letter basically saying exactly what you just said, in the sense of that this is the life we live every day. And I've tried to explain that to people too. This is the life we live when the flu hits. This is the life we live when the day changes. It's just how we are. And so I think it's going to be reassuring to people that they don't necessarily have to travel to a big university or a big college campus to participate in this study.
We're gonna figure it out. That we just need to talk to you and get you signed up, and then we're gonna work on the details.
That sounds promising.
We're going to put the details of how to join the study below. We're going to also add the consensus document below, as we just discussed. Dr. Tobin, we have very few doctors as passionate as you involved in SDS, so we just want to thank you again. You've been a 2-time camp doctor, and we just thank you again for championing our patients. Thank you so much.
It's my pleasure. I want to also, Rick, say when you look at that SDS document, please note that there's a lot of things on there that are, what I'm trying to do is change that document because I think it's missing what we need to talk about here. And they won't change that document unless we have the data.
Exactly. That's a huge point, Dr. Tobin. Thank you so much. Because it sounds like this is a uncharted territory that you're talking about. So we need to gather data to update that document. Anything else? Do we have any other questions?
I think this was I think we had all the questions answered.
Thank you guys so much for joining us. Stay safe. Again, just a reminder, we have Dr. Liu, an adult SDS hematologist with us on Sunday for a special SDSF Live. Michelle and I had this scheduled already. We've actually moved Dr. Tobin 3 times because of the coronavirus, but we still thought it was important to bring him on today. But we'll have a special coronavirus update on SDS on Sunday. Thank you so much, Dr. Tobin, and we will try to get any questions that we missed answered through you. Thank you so much. Have a great night.
You too. Thank you again. Bye now.
Thanks, Dr. Tobin.
Thank you, guys.